Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to the 11th webinar in the Women's Health 2024-2025 series. Today's webinar is titled New Treatments for Vasomotor Symptoms Due to Menopause, featuring Dr. JoAnn Pinkerton, Professor of Obstetrics and Gynecology at the University of Virginia. Today, JoAnn will delve into the vasomotor symptoms associated with menopause, the current understanding of physiological mechanisms involved, and the pharmacotherapies and treatments available. Before we get started, I would just like to acknowledge our partners for this series, the American Physiological Society, the Society for Women's Health Research, and Scientist.com. We'd also like to say thank you and give a shout out to all of our series sponsors. None of this would be possible without them. I'm Sarah McFarland from the events team here at Scientist.com, and I'm happy to be your host for today's event. Before we get going, I just wanted to cover a few housekeeping notes to help you get the most out of your experience today. First, take a look at the interactivity panel at the right of your screen with 4 tabs: Chat, Q&A, Polls, and Handouts. This is where you'll participate in the Q&A as well as access all webinar resources. We want this to be an interactive experience for you, so please send your questions, thoughts, and comments using that Q&A tab, and we'll try to address as many of your questions as we can at the end of the webinar today. You can also explore some links in the Handouts tab to learn more. And lastly, if you're having any technical issues, please try refreshing your browser and ensure that you're using Google Chrome to access this event, as it is the most stable browser. If you're still having trouble after you refresh, use that private chat function to communicate with me by sending a chat to Sarah, and I can help to troubleshoot. All right, and I did just want to have a quick note here. JoAnn did actually have to be in clinic today, but we've recorded her presentation, so we will play that for you, and she will be joining after the recording plays for a live Q&A. So just like any other webinar, send in all of your questions. She's here, and she'll address them live as soon as her recording finishes. And so, without any further delay, I'm very pleased to play her recording for you.
Hello, I'm Dr. JoAnn Pinkerton. I'm a professor of obstetrics and gynecology at the University of Virginia and have served for the Menopause Society in many roles. I've recorded this lecture because I'm in clinic, but I will be here for the live Q&A and looking forward to your questions. I do have disclosures. I may mention the use of FDA-approved therapies as well as non-FDA-approved therapies that we use off-label. They've all been tested if they're mentioned. I have grant support that has been coming from Bayer Oasis 2. I was the UVA lead as well as the US lead. Fees went to the University of Virginia. I've been a consultant for Bayer and for Pfizer, as well as UpToDate and Merck, and I serve on multiple editorial boards. Today what I want to talk about is understanding the risk factors and the impact of menopause and vasomotor symptoms on health, work, relationships, and quality of life. Evaluate traditional treatment options for patients with vasomotor symptoms due to menopause, both hormonal and non-hormonal. Assess some of the pathophysiological mechanisms that have been identified to date that can result in vasomotor symptoms due to menopause, and then review these new and emerging pharmacotherapeutic non-hormone neurokinin receptor therapies for vasomotor symptoms. So what is the menopause? The menopause is defined as your final menstrual period, and it is diagnosed retrospectively. So if your last period was January the 1st of 2024, on January the 1st of 2025, I can say you're a year without periods and you're menopausal. It's important, though, to recognize that it's not an on-off switch, and that starting in your 20s and 30s, you're in your reproductive part of your cycle. Then you enter into the perimenopausal time, which I personally think is much harder because of the fluctuating hormones. Then the defined time when you haven't had a period for 12 months, which is menopause. And then you enter into postmenopause, both early, closer to menopause, when you still got some hormonal fluctuations, and then later in postmenopausal when your ovaries are really not working at all. And to put those into actual words. So we define it as 12 months of amenorrhea or no periods. And it's because you've lost your ovarian follicular activity. You're not ovulating, and then you're not making as much of the female hormones, estrogen and progesterone. The median age is 51.5, but it's a bell-shaped curve, goes from 45 to 55. And the menopause transition leading up is about 4 years. Now, about 80% of women worldwide suffer from vasomotor symptoms, also called VMS, and they range in severity. They can affect quality of life, overall health, and about 25% are severe enough that they need treatment. On average, they last about 7 years, but they have now been associated in research trials with cardiovascular disease, osteoporosis, and cognitive complaints. And women who experience vasomotor symptoms during perimenopause may continue to have them for much longer, a median duration of almost 12 years, and a few women keep having them into their 70s and 80s. Race, ethnicity, comorbidities, lifestyle factors, stress, psychosocial factors all affect menopausal symptoms. So now I'm going to talk a little bit more about what these vasomotor symptoms are, and I'm going to start with the physiological mechanisms. What's going on? Well, you're actually vasodilating the cutaneous vessels in the skin. The skin temperature goes up, and then you get vasodilation and sweating, and it feels like heat dissipation. And what happens, if you look on the slide, there are asymptomatic women who have a really nice wide sweating threshold and symptomatic women who have a narrowed threshold. So they're more likely to get a sweat when the body temperature rises, or shivering when it falls. And I can just remember being menopausal, turning on the heat when I was sedentary, and then I go to the bedroom and I'm like, I want the air conditioning. My husband says you can't have both. I'm like, yes, I can. I'm in menopause. So just learning that that's about your temperature zone is just narrowed. Now, what are the most common symptoms? Hot flushes, night sweats, right? Hallmark symptoms. And these are sudden intense sensation of heat, often starting in the upper chest area, may last 1 to 5 minutes, may be accompanied by chills, sweating, feelings of dread, or palpitations. And then if they occur at night, we call them night sweats, and they often wake women up from sleep. Could just feel warm, covers on and off, could be soaking sweats, having to change your bedclothes or your sheets. And when we're doing clinical trials, the FDA has defined vasomotor symptoms as mild, heat without sweating, moderate, heat with sweating, but you can continue your activity, or severe, heat with sweating causing cessation of activity. And in general, for clinical trials on hot flushes to get through the FDA, women have to have 50 moderate to severe hot flushes per week in order to qualify to be in the studies. But I also wanted to mention sleep, because somewhere in the perimenopause time, we start to have discomfort with sleep. Might be poor sleep quality, insufficient sleep, waking up at night, or being diagnosed with sleep apnea. And what we know is that when women don't sleep well, it increases the risk for heart disease, diabetes, obesity, cognition, and 40 to 56% of women during menopause and perimenopause complain of sleep compared to premenopausal women. And what's the impact? I mean, isn't it just a nuisance? You just get hot, take your sweater off. Well, it actually turns out that if you have frequent vasomotor symptoms more than 6 days in the last 2 weeks, you have higher anxiety, depression, sleep issues, and impaired quality of life. And in a multinational survey, almost 3 out of 4 postmenopausal women complained of fatigue, and 2 out of 3 had difficulty sleeping. The costs are higher, which has been shown by Dr. Fabian in her Mayo study, healthcare utilization and associated cost. And then despite this, when they talked to and surveyed 1,000 women, 40 to 65, 73% of women had not received treatment for the vasomotor symptoms. So it is a clear unmet need. So I just want to present Amanda to you. She's in her late 40s. She complains of amenorrhea, hot flushes, fatigue, irritability. She's having hot flushes 6 to 8 times a day. They're moderate to severe intensity. Her sleep is disrupted 3 to 4 times every night, covers on and off, soaking sweats. She's having mood swings and irritability that are affecting her partner, her work, her family. She has tried black cohosh, ashwagandha, soy, magnesium. She's miserable, and she comes to you for help. Her sister had breast cancer at 60. She doesn't want to talk about hormone therapy, think about hormone therapy, or take hormone therapy. So I think it's really important to look at the landscape when people have vasomotor symptoms. So we have lifestyle modifications, running fans, air conditioning, mind-body behavior, acupuncture, hypnosis, non-prescription therapies such as she tried, prescription treatments that are non-hormonal, and then hormones. And I'm going to go through a really quick review of the Women's Health Initiative because this sort of stopped women's health research for quite a period of time. That study, that landmark study, was women ages 50 to 79. They had 10,000 women who had had their uteruses removed, hysterectomy. 16,000 women had their uterus. If you had your uterus removed, you took estrogen alone. If you had your uterus, they used conjugated estrogen with a potent synthetic progestin called medroxyprogesterone acetate. So this was the first study that came out, and across the CNN ticker tape, it was 29% risk of heart disease, stroke, breast cancer, 26%. Everybody assumed they had a 1 out of 4 chance of breast cancer because these were relative risks, not absolute risk. And then there were benefits on hip fracture and colon cancer, but they stopped it because of the harm. And then in women who were 65 and over who already had white matter changes on their MRI, they saw an increase in dementia. So if we look at the estrogen-only arm, uterus out, estrogen alone, it was very different. They stopped it early because there was an increased risk of stroke in these older women with oral hormones. But what you see is it did decrease the risk of hip fracture by almost 40%. And there was no increased risk of heart disease. There were actually 7 fewer breast cancers and less colon cancer, and total mortality was not increased. So very different populations. But what was very interesting was that we quickly discovered that this study was primarily women average age 63, not the women we usually use this for. And so in 2007, they actually put the two studies together and looked at it by age from a time of menopause and when they initiated their hormone therapy. And what you found is if you started your hormone therapy in the group we think it's safest, 50 to 59, you see the blue, less heart disease, no increase in stroke, a slight increase in blood clots because it's oral, that decrease in breast cancer driven by the estrogen-only arm, and total mortality was decreased. If you look at the green group, that's the people coming into my office now who said, I didn't get my hormones, talk to me about it. That's kind of a gray zone, mixed results. And if you look at the women who initiate over age 70, so they are in the orange, you see that we increase the risk of heart disease, of stroke, of blood clots, and total mortality. So it's really important to think about when you initiate hormone therapy in terms of risk for women. And then if we look at just the women we think that it's safest for, 50 to 59, and I separated on this slide estrogen with progestin at the top, if you have a uterus, and estrogen alone, you see a lot more red in the group with the medroxyprogesterone acetate for heart disease, stroke, blood clots, and breast cancer, although we have a benefit in fractures and cancers and diabetes. Estrogen alone, you only see a slight increase in blood clots, and everything else, heart disease, breast cancer, colon cancer, fractures, death, and diabetes were decreased. So that's an important piece that we share with women. And then we also now have so many more different doses and types of therapies. So we often use transdermal therapy, which is through the skin, and that lowers the risk of blood clots and stroke because it doesn't go through the liver, doesn't increase sex hormone binding globulin. No head-to-head trials, but is well believed in the literature. And we use it if you have migraines, depression, you do shift work, if your libido's down, or if we need to avoid your liver because of diabetes or gastric bypass. And then the last thing on hormones that I wanted to share in the WHI study was breast cancer risk, because what they said was just a family history didn't increase your risk of breast cancer more than your risk just from your family history. And then if we look at people who took hormones, the placebo group is the 2 lines in the middle. green and orange. So you can see that your risk of breast cancer goes up as you age, which is why we don't stop mammograms. If you look at the group that took estrogen and the synthetic progestin, they started to go up about 5 years and stayed that increased risk all the way up to 22 years, long after they'd stopped the hormones. And if you look at the estrogen-only arm, it's in green. You see that by around 4 years, they started having fewer cancers, and that was maintained all the way out. Same thing for total mortality. The other important piece to think about when we're doing clinical trials is about women who have early surgical menopause or primary ovarian insufficiency. They're under 45, they're under 40, going through menopause, and we now know that that has risk of heart disease, osteoporosis, fractures, genitourinary symptoms. And so those people are always going to be a candidate for hormone therapy until at least the average age of 51. So that's kind of painting where we are with hormones. Now let's talk about non-hormone therapy. And again, we're just talking about vasomotor symptoms. And this is a slide that, unless you're a clinician, you don't want to know all the data on this slide, but on the far left are the types of therapies that we use for hot flushes that have been tested in randomized clinical trials, but not all of them are approved by the FDA. So gabapentin, paroxetine, escitalopram, so SSRIs, serotonin uptake inhibitors, and then the SNRIs, serotonin norepinephrine uptake inhibitors, like venlafaxine. An overactive bladder medicine called oxybutynin helps hot flushes, and clonidine. And so the only one of those that's FDA approved is a very low dose of paroxetine, but often the insurances make us try these before we get to try the newer, more effective medications. And in 2023, the Menopause Society came out with what they recommend based on randomized clinical trials, and that was cognitive behavioral therapy, hypnosis, the antidepressants and gabapentin, oxybutynin, that overactive bladder medicine, weight loss, a scary procedure called a stellate ganglion block, which is near your external carotid artery, and fezolinetant, which we're going to talk about, which is now available on the market. And all the things on the right that may or may not have a benefit, they didn't have good trial data for. So where are we going? What are these new and emerging pharmacotherapeutic options that we think are going to better manage vasomotor symptoms for women who can't take hormone therapy? Well, recent research has shown that vasomotor symptoms result from a hyperactivation in that thermoregulatory pathway, but it's mediated by hypertrophy of the KNDy neurons when the estrogen declines at menopause. And inside that center, these neurons, which are known as the KNDy neurons, kisspeptin, neurokinin B, dynorphin, they're involved in regulating the body's temperature, and they are inhibited by estrogen and stimulated by neurokinin B. It's kind of a delicate balance. And the next slide puts it into perspective to kind of see it. So these NK3 neurokinin 3 receptors in the hypothalamus, these neurons hyperactivated when your estrogen level drops, and they also work through neurokinin 1, a second neurokinin receptor, neurokinin B, and something called substance P. And so for those who really want to understand hot flushes, you have to learn all these words. For those of you who don't, just know that this is going on in your brain. So the NK1 and NK3 antagonists are where the treatment options are coming from. And it appears that we can disrupt the pathway if we antagonize these neurokinin receptors and therefore help hot flushes. We started out with some neurokinin 3 receptor antagonists, and they led to liver issues and were taken off the market. And then we have one that got FDA approval in May of 2023, fezolinetant, and then one that is in testing and is currently at the FDA under review, elinzanetant, which has have finished their phase 3 trials mostly and has a phase 4 already underway. And fezolinetant has a phase 4 underway also. So I want to talk about fezolinetant first because it's here, it's available, it's effective, it works rapidly, it works not quite as well as hormone therapy. Meta-analysis on hormones is 75%, fezolinetant was about 65%, but it's very rapid within a week and appeared to have a good safety profile, including endometrial safety. Because of all the concerns about liver. They had special liver monitoring, which I'll show you in a minute. But this is just a slide of the data. And just to walk you through this, what happens is that there is placebo response to hot flushes. It's about 50% response in the literature. And so these women started out having 12 hot flushes a day. If they were on placebo, they went down to about 10. But if they were on either dose of fezolinetant, 30 or 45, they went down to 8. And then they kept going all the way down to about 5 hot flushes a day. So it didn't take them away completely, but a pretty dramatic improvement. If we look at severity, it's always harder to help the really severe ones. You can see placebos in the gray. The 2 doses are green and blue. And again, over time, they did improve the severity compared to placebo with a dose response. When we look at the data for concern about hepatotoxicity, which is one of the big concerns, this is a plot that shows it's got 4 areas. You want to be in the left lower quadrant. You want to be in the normal range. And you can see that the majority of the placebo that were circles, fezolinetant, low dose 30 in blue and 45 in triangles, all centered around normal. A few scattered ones of all types in the elevated test, liver test, but not high test, and 1 level of hyperbilirubin, and nobody in Hy's law, which is really hepatotoxicity, where your bilirubin goes up, your liver test goes up, and you have to go off medicines. And for those who did have elevated liver tests, they were able to either stay on the study, stop the study, and they resolved. So there wasn't a lot of concern about it. The FDA was worried enough about it that they asked us to get baseline liver tests on everybody and repeat them at 3, 6, and 9 months. They do post-marketing, and then there one post-marketing case came in that caused them to add a boxed warning about a rare occurrence of serious liver injury with fezolinetant. It was post-marketing. It was in about 40 days. She complained of fatigue, nausea, itching, yellow eyes and skin, light-colored stools, dark urine. Her liver tests were elevated, enzymes and bilirubin. They stopped the medication. Everything gradually resolved. But because that happened so early, before the 3-month time, that they're now recommending baseline 1, 2, 3, 6, and 9-month liver testing. So it's a lot of testing, and it makes people more concerned when, this was one post-marketing case, and you saw the relative safety data from the prior slide. So if we move into the area where I'm more focused in, which has been a newer product called elinzanetant, it is a dual antagonist. It gets both neurokinin 1 and 3. It blocks NKB and substance P, which we think is involved in sleep and mood, and it's 120 milligrams, so the doses are apples and oranges. And when we first came out, our top-line data, it worked fast within a week. It reduced the frequency and severity of hot flushes, improved sleep and quality of life. And I'm going to go through some of that data with you to actually show you the data. So this was OASIS 1 and 2. The FDA requires that we have 2 similar studies done in the US in order to be able to, as well as other countries, in order to get it through the FDA. So they were OASIS 1 and 2. They enrolled OASIS 1 had about 396 women, and OASIS 2 had about 400 women. The way it worked was they were randomized. They had to show they were having 50 moderate to severe hot flushes per week. Then they were randomized to either placebo or elinzanetant 120 milligrams, followed for 12 weeks, double-blind, randomized controlled trial. And then at the end of 12 weeks, everybody was then given elinzanetant for the next 14 weeks, and then we followed them up for four weeks. And that was published in JAMA in September of 2024. I wanted to show you the demographics because it's always important to know who did you test and treat. So these were average age 54.7. They were 78% to 80% Caucasian. We did have a good Hispanic group of 18 to 16%, some Latino, really not any Native American or Asian, and they were not significantly overweight, and we had smokers and non-smokers, and we had about a third had had their uteruses out, and about 18 to 20% had had their ovaries removed, and they were about 4 years out from their last period. So this was the group that we tested. And just to show you the data, which was really, the data in the two studies was so similar that when we went to JAMA, we said we want to actually publish both studies together. So you see on the left will be OASIS 1, and on the right is OASIS 2. And what you see, the gray line is the placebo group, and we had our 50% improvement on placebo. But if you look at the blue line, which was elinzanetant, within a week, we had a significant decline in hot flushes, and that continued all the way until we switched. When we switched everybody over to elinzanetant at 12 weeks, what we saw was the placebo group rapidly improved their hot flushes. The elinzanetant group continued to slowly improve their hot flushes. And then when we stopped them at 4 weeks, they came back about 50%. And those two graphs, you can just see they look very, very similar with prior to the crossover and at the crossover. If we then look at the severity, this is where it's exciting because I think the severe ones are always the harder ones to treat. You can see that placebo did not work as well in either trial for severity. And again, that's the gray line. We did have a decline. And then once we switched everyone over to elinzanetant in both trials, we had a rapid improvement in the severity that was maintained until it was stopped. And if we look at the elinzanetant by itself, we had a rapid decline and then continued improvement in the severity all the way to the end of the 26 weeks. And then once we stopped it, severity started to increase again. Treatment emergent adverse events, things that we care a lot about, were really mild. It turned out that in both trials they were similar, headache and fatigue, and then OASIS 1 had more arthralgias or joint aching. And we divided this into two parts. One was the elinzanetant placebo, and we looked at those two studies in the two trials, and then we looked at the group that switched from elinzanetant to elinzanetant. And the number of adverse events went down, and we didn't see any liver injury, we didn't see any endometrial cancer, we didn't see any major treatment emergent adverse events. So kind of summarizing those 26-week studies, it reduced the frequency and severity of hot flushes. I didn't show you the data on sleep. We used PROMIS for our sleep measure, and quality of life was the menopause-related quality of life. Headache and fatigue, most commonly reported treatment events, and no liver hepatotoxicity signal. And then the next study has not been published, but it's the 52-week trial. And I'm going to show you that next. And in that study, what you see was 628 women, 83 sites, 9 countries, and they were monitored over 52 weeks. We again wanted to show the effect at 12 weeks because that's what the FDA wants to see. And what you can see is the gray again is placebo, and they had a decline and maintained an improvement in hot flushes during the trial. But the elinzanetant group had a very rapid decline in the frequency, and they maintained it over the entire time of the trial. And if we look, and severity was similar, I didn't pull that data, but they worked for frequency and for severity and were statistically significant. And if we look at the treatment emergent adverse events in the safety analysis set, so this is our 52-week data, you'll see a lot of things come out. People get colds, they have runny noses, they get headaches, but very few led to discontinuation of the study drug. There were very few serious transient emergent events, and of the ones that more than 5%, headache, COVID, fatigue, somnolence, and a runny nose. And split between the two groups. So really nothing that we saw that was of concern. And if we look at the liver test here, so this is elinzanetant, so the neurokinin 1,3 dual neurokinin receptor antagonist, you see the same kind of plot that we saw with fezolinetant. You want to be in the left lower quadrant, and almost all of them were. The placebo is the white, and then the black is the elinzanetant group. Almost all of them were centered around no effect. There were a few cases in both groups of liver tests going up, and they went away on their own or when they stopped. No incidence of elevated bilirubin, no incidence of any severe hepatotoxicity. And when you took a look at all the data, we saw no endometrial hyperplasia, no cancers of the uterus, which you don't expect, right? It's not an estrogen, it's not affecting the uterus. The change in bone density didn't change. We had age-associated change, but it is not an anti-estrogen at the level of the bone because it's really just working in the brain. It's a central action. Weight was stable. People didn't lose weight. They didn't gain weight. There was no hepatotoxicity signal and nothing that was associated with acute liver failure. And we had a liver data safety monitoring board for that. This data has been presented at the NAMS meeting and is in process of being published, but is not published yet. If we summarize the 52-week study of elinzanetant, it was efficacy and safety for treatment of moderate to severe hot flushes. The difference in this trial was women had to be complaining of moderate to severe symptoms, but we didn't count them. We didn't have, electronic diaries where they had to show they were having 50 a week. So it's more indicative of what we'll see in clinical practice. And by 12 weeks, we could show that there was a reduction in both frequency and severity of the hot flushes maintained throughout the entire study duration. We did the measures of sleep disturbance and menopause-related quality of life. Again, they improved. And so it really supports that the 26-week trial data was confirmed in the 52-week trial data, and it's in a group that's a little bit more indicative of clinical practice. So where is this now? It's at the FDA, and we're hoping that the FDA will favorably review it so that it can become available for women, because to have a therapy that treats hot flush frequency and severity, improves sleep and mood, it's the triad of what menopausal women suffer the most from. So it will help them clinically, it will help them if they're your partner, it will help them if they're your colleague, because they're going to be able better to function if they get sleep, if their mood is better, and if their hot flashes are better. So I'm really excited about this data. What is coming is, first of all, Oasis 4, and that is another phase 3 study where they took women who were either had breast cancer or were at high risk of developing breast cancer, and they had to be on treatment, either tamoxifen or an aromatase inhibitor. It was done in 90 centers, 16 countries, not in the United States. It was a 52-week trial, and we have early data from that. And then people could optionally stay in the trial for 2 years. So at the end of this, we'll have 2-year data. They were having to have moderate to severe vasomotor symptoms. Again, at 12 weeks, we saw reductions in the frequency and severity of the vasomotor symptoms at 4 and 12 weeks. Rapid at week 1, maintained over the entire study duration. So very similar to our group of people not on those medications. And the safety profile was generally consistent. And we will see more of that data, hopefully in the next few months when it gets published. The next piece that was so interesting was we had hoped that elinzanetant, because of its function as a dual neurokinin receptor inhibitor, going an antagonist to both neurokinin 1 and 3, that it might really help sleep. And it did improve sleep disruption in the trial. But those were women who were enrolled not because they had sleep disruption, but because they had hot flashes. So the Nirvana trial is a trial, it's a phase 2, where you do have to have sleep disruption to be able to enter the trial. And you have to have nighttime awakenings, poor sleep quality, a wakefulness after sleep onset called the WASO, and it's being measured by the gold standard of polysomnography. And the primary objective is to look at how well elinzanetant works on sleep disturbance associated with menopause using this objective measure. And then we're also going to be looking at self-reported sleep using these handheld devices, PROs, We'll look at safety. And then there will be a group that's going to be a subgroup of participants using a touchless sleep monitor that's going to assess their sleep quality in a realistic home environment, in addition to the polysomnography. So we'll really get our handle around what women who have sleep disturbance as their primary reason to want to be on therapy might benefit from elinzanetant. And the reason that this is important is that 25% of people need treatment for hot flushes and night sweats, but we have people who just have anxiety or just have mood issues or just have sleep issues. And the question is, would they benefit from treatment? And what health benefits on heart disease risk might they get if we decrease those hot flushes? Because there is data showing improvement in heart and in cognition if you improve hot flashes. So we're excited to see where this data goes. So if we go back to Amanda, who, remember, I just remind you, hot flushes 6 to 8 times a day, disrupted sleep, mood swings, sister with breast cancer doesn't want hormone therapy. We talked to her and we said, we have these off-label low-dose antidepressants. She doesn't want to take them for relief of hot flushes. You could try gabapentin, approved for diabetic pain, but we have shown that if you take it at night, it does help night sweats. The side effect is drowsiness. She had tried it, was too drowsy, sensitive to it, didn't want to take it. We offered her oxybutynin because she had a few little urinary urgency. She goes, nope, side effect is dry eyes. I don't want to take that. She has normal liver test. She's not taking any of the medicines that would make her contraindicated to fezolinetant, which are these CYP1A2 inhibitors, cimetidine, too much coffee, there's some of the antidepressants. We explained in general terms that if she took this, that it would really only work on the hot flushes and night sweats, and that's how it works. It's going to improve her sleep if she has fewer sleep disruptions from the hot flashes, and that it does work just centrally in the brain, and that it's not going to help any bone loss or vaginal symptoms because it's not an estrogen. And she was really excited to try it, to try and get control of her hot flushes. So Amanda took a neurokinin receptor antagonist, the one that was available by the FDA, fezolinetant. Within 1 to 2 weeks, her hot flushes decreased from 8 to 10 a day to 1 to 2 per day, were less severe. Her night sweats almost completely resolved, so she was sleeping better. She felt her quality of life increased. And very similar to one of our study participants who, when I talked to her about how she felt about being in the clinical trial, she just said, I wish I could stay on this forever because my hot flushes are better, my sleep is better, my mood is better. And later on, we took her off and put her on something else. And she said, well, my hot flushes are better, but my mood is not quite as good. So I think that we're going to be able to look at these medications and aim who they're going to help the most. And then I know you're primarily a scientific group, but I'm a clinician. So I always want to bridge that gap between evidence and personalized care. So if you look at the left, if you come in and talk to me and say, you know, I'm under 60, I'm within 10 years of menopause, I've got bothersome hot flushes and night sweats or bone loss, and I'm interested in taking hormone therapy, you'll be a good candidate. We'll talk about the boxed warning. We'll talk about potential risk. Think about whether we need to use a transdermal patch or gel, and then start hormones and just reevaluate annually, and then decide how long to stay depending on our risk factors. If you're my intermediate group, your age is okay or time for menopause, but you've got a contraindication to hormone. You've got an elevated risk of breast cancer, or have had breast cancer, or endometrial cancer, or you've had a heart attack, or a stroke, or a blood clot, or you have migraine headaches with aura, or you have other comorbidities like apoprotein S syndrome, the lupus syndrome. Those are the people that we're going to say, okay, maybe hormones, maybe not. Let's talk about the non-hormones. Maybe we'll try them first. And those are in that box in the right lower quadrant. Paroxetine salt, low dose approved, and then and fezolinetant would be approved, and then off-label the low dose antidepressants, gabapentin, oxybutynin, and the one that we just showed you the data on elinzanetant if it gets FDA approval. And that same options would be given to people who come in and they're over 60, particularly if they're over 70, and where the risks might outweigh the benefits. Consider the non-hormone therapy. And the gray group, the hardest group, are the ones that are coming in now who are 63, 65, 70 and said, I missed my hormone therapy and I want to try, and trying to decide what's the risk benefit versus are they having hot flushes? Would they be a candidate for a non-hormone such as fezolinetant or elinzanetant or one of the off-label medicines? The next slide that I wanted to show is just the president put a memorandum out on women's health research and really said that we have big gaps in medical research. And that's for things, diseases and conditions that only affect women, menopause, endometriosis, fibroids, for diseases and conditions that disproportionately affect women, like Alzheimer's disease, diseases and conditions that affect men and women differently, like heart disease. And then bigger gaps also occur for women of color, women with disabilities. And so for those of you who are researching, these are the areas that we really want to look at. And I want to, of course, make a plea for menopause because 15% of women missed work or cut back on hours because of menopause symptoms. The loss of productivity was estimated at $1.8 billion per year. Employers are adding menopause-specific care to their benefits, but a lot of times they are just using telehealth with people who are not really trying to individualize care. They're just trying to say yes, no to hormones versus, being at a menopause center where you can really get individualized care. And with that, I was very excited to share my research with you today. I'm at the University of Virginia. I'll be here for your questions and answers and can't wait to hear from you. Thank you.
Okay, I am going to bring Dr. Pinkerton on now. And while I do that, I did want to remind you that the Q&A tab is there on the right side of your screen. So send any questions that you have for our lovely speaker today. Hi, JoAnn. Thank you for coming. Thank you for being here. We're so excited to get to these questions. We have quite a few. But before we do, I did just have to launch our survey. So if anyone has to leave early, we'd love to get your feedback there in that survey. Okay, so lots of questions, and we're going to get started if you're ready.
I'm ready. It's snowing nicely outside, which is exciting, except for when it's time to go home.
Yeah, no, I completely understand. We're getting the same snow here. Okay, so first question is, it's a really nice presentation. I've just missed the role of neurokinin in thermoregulation. Would it be possible to explain it one more time, please?
So the current theory is that when estrogen levels decline, they lead to a hypertrophy of the candy neurons that are in the brain. And these neurokinins turn out to play a role in thermoregulation. And so when estrogen declines, you get a hypertrophy and hyperactivation of those neurons. So what the research is showing is that if you block those neurokinin receptors, particularly neurokinin 3 and neurokinin 1, you're going to decrease the signaling pathway, and therefore the hot flashes decrease. And what we found with fezolinetant, which is a neurokinin 3 receptor antagonist, we had an improvement in hot flushes, improvement in sleep because there were fewer hot flushes, not quite as good as with hormone therapy, but similar, maybe 65% versus 80%. And then elinzanetant, which is the new one, is a dual neurokinin receptor antagonist. So it's going to be blocking neurokinin 3 and neurokinin 1. And what's important in that is that neurokinin 1 works through the substance P. And so that's why we believe we're seeing the improvement in sleep and in mood. So it's complicated. The easy way I tell patients is if you're having hot flushes, your thermoregulatory zone has narrowed, so you're more likely to get hot or cold. But now we understand that it's actually happening at the hypothalamus, coming down to the pituitary, to that thermoregulatory zone, understanding it a little bit better.
Amazing. I hope that helped for our audience member there. We've got another question here asking about beta-3 adrenergic receptor agonists like mirabegron. Do they improve vasodilator dysregulation variability?
So what I can tell you is that oxybutynin has been tested and actually does a really good job not only helping overactive bladder, but it does decrease hot flushes, works better if you're doing up to 10 milligrams a day. And so we know that. The newer ones, the ones that are less likely to give you dry eyes and dry mouth, and also less likely to affect cognition like Metarabic, haven't been tested to the best of my knowledge. So I think it's an open area for research.
Okay, perfect. We've got another question here about cognitive effects with elinzanetant. So, is there any alleviation of memory issues associated with perimenopause?
So first of all, elinzanetant has not been tested in perimenopausal women. You had to be either surgically menopausal or a year without a period and have documented elevated FSH, and that's true for both fezolinetant and elinzanetant. So they haven't been tested in perimenopausal women when you're having your fluctuating hormones, but you might start having hot flashes. What we do know is that when you improve hot flushes and sleep, brain fog gets better. So the same things that we found with hormone therapy, we're finding in our postmenopausal women with these therapies. Definitely their brain fog is improving. I think once we get elinzanetant approved by the FDA, it's under review right now, then the question is, are there different types of populations that we can look at? And perimenopause is one of the ones that most of the investigators have a really strong interest in. We wanted breast cancer, and the good news is, as I told you earlier today, it works for women on tamoxifen and on aromatase inhibitors. So that's our primary population. And then our typical symptomatic menopausal women who can't or won't take estrogen. But you were right, our perimenopausal women are coming in and wanting help with their symptoms. And many times we're trying hormones if lifestyle changes don't work for them.
Amazing. I'm excited for that research to kind of progress. That's going to be great. This is a long one, so bear with me. I'm just going to read it. Awesome research. Our lab studies the relationship between cardiovascular disease and vasomotor symptoms, and there's a fair amount of evidence that severe hot flushes are related to multiple risk factors for cardiovascular disease, like endothelial dysfunction, increased LDLs, increased resting blood pressure, etc. There's several potential mechanisms we look at in our lab that might be driven by not just the cessation of estrogen, but stopping the hot flashes themselves. Did you find any data that reversing these hot flashes might also reduce these risk factors?
So that has not been a focus of the research yet. I mean, we really looked at hot flushes, sleep, and mood. We did not find any weight gain or significant weight loss, but I don't know if so I'd have to go back to see if we have cholesterol levels. We probably do, and we can probably look at those, but I think it's going to require specific study to look at that. And Rebecca Thurston up at Pittsburgh has been one of the leaders showing that just the vasomotor symptoms themselves are associated with both heart issues, cognitive issues, and also bone issues. So what we're hoping is that we will be able to see an improvement when the hot flushes get better in terms of cardiovascular risk, and maybe in cognition. We don't expect to see it in bone density. We do have year-long study on bone density and only saw the age-associated loss, but because it's not increasing estrogen, that's not a surprise on the bones. We would expect and hope that there'll be a benefit and look forward to that research. And I know that the companies that make these would be delighted once they get a little further in their programs to be able to fund some of this research.
Absolutely. There's a very similar question here about reducing the long-term associated comorbidities with the vasomotor symptoms like dementia, heart disease, osteoporosis. So I think you've already addressed that.
Let
But
me say one thing.
yeah,
The good news is these neurokinin receptor antagonists are not hormones, which means that women who aren't candidates or don't want to take them have something that they can take that's going to for sure help with the hot flushes and with elinzanetant, maybe mood and sleep. But they are not estrogen. That's the downside. So we may not see the same benefit on lipids, on bone, and we just don't know about cardiovascular and cognition. I actually think, based on Rebecca Thurston's work, that when we improve the vasomotor symptoms, we're going to decrease those risks, but we don't know that yet.
Absolutely. Thank you. We have another question here about the contraindications for hormone replacement therapy for women with migraine with aura. Can you share a little bit more on that topic?
So the initial data came out of the oral contraceptive literature and showed that if you were using oral contraceptives and you had migraine with aura, you had an increase in stroke. And so that has been considered a caveat for birth control pills not to do it. And particularly for hormone therapy that is oral, that same concern. What we've discovered, though, is that for some women, their migraines actually worsen when their hormone levels drop. And if you give them a transdermal estrogen and keep their hormone levels stable, they may not worsen. So if someone has a migraine without aura, I am very willing to try an estrogen patch during the placebo week of their birth control pills, or try a transdermal hormone therapy with progesterone if they have a uterus. If it's migraine with aura, I feel like I'm dancing on thin air a little bit, but I will often have an informed discussion with the patient, have them see a neurologist so that we have the best control of the migraines that we can get, and then give them a 3-month trial. If their migraines aura are worsening, then they are not a candidate. If they actually improve, which sometimes happens, then we just continue to reevaluate how we're doing with them. We would always want to do low dose, and we'd always want to do transdermal.
Okay, perfect. Thank you. We've got, oh my gosh, there's so many questions coming in. This is amazing. Keep sending them in. This question is about the study. Okay, so I was surprised by how many women participated in this study that had undergone a hysterectomy. What are the main causes when it is indicated to go through that procedure? And is there any way of presenting that?
So hysterectomies are usually done because of abnormal bleeding, fibroids that continue to increase in size during perimenopause, any kind of precancerous cells in the uterus, and any type of cancer, sometimes done for cervical dysplasia if conization doesn't work. So there's usually a medical reason why people have hysterectomies. When I first started practice, we could do them for misery. We can't do them for misery anymore because we've got medical, therapies that work to control bleeding. But many times there's a reason why that woman has had a hysterectomy. And then the other piece is whether or not they've had their ovaries removed. And data has shown that having early surgical menopause increases health risks of heart disease, bone loss, cognitive issues, Parkinson's, glaucoma, sexuality issues. And so, most OBGYNs are trying to delay removing ovaries until closer to the median age of menopause, which is 52. But for some women, for example, if you have the breast cancer gene, we really want to get those ovaries out by the time you're in your early 40s to decrease your risk of ovarian cancer, which we can't find early and we don't have good treatment for. So when we do a study on hot flashes, we want to get naturally menopausal women, but we also want to get women who've had hysterectomies and women who've had their ovaries out, because we want to see if it works as well in those populations. And often early surgically menopausal women have the most severe hot flushes, and so that's been a good group. And so in the study, we had about a third of women who'd had a hysterectomy, and about 20% had had their ovaries out. And to date, when we looked at the data, we didn't see any differences. So elinzanetant, at least the one that I was familiar with, did not appeared to work in all those populations. I hope that answered the question.
I think it did. Yeah. Thank you for that.
Can I throw one other thing in? You may hear a lot about the Mirena or different types of progestin IUDs because we're now using either low-dose birth control pills or these progestin IUDs during perimenopause for heavy bleeding, and they have a benefit that then as we need to add estrogen, it's already protecting the uterus, and then we can just add estrogen in. So it's one of the newer ways that we're handling perimenopause for women who have bleeding problems.
Excellent. Thank you for that. Still, gosh, so many questions. This is fantastic. We've got a question here about the neurokinin 3 receptor antagonist treatment. So, does this treatment modify thermoregulation besides mitigating the hot flashes? Like, does it change anything else about the way that these women thermoregulate?
I'm going to answer that as a no, because of being a PI in one of the clinical trials, we found that it does decrease the severity and frequency of the hot flashes, but they still, if they're running a fever, they would run a normal fever or get chills just like normal. So if you get the flu, you're going to get the same normal response. It's really working on the signaling pathways that are involved in triggering the hot flashes, not just in changing the thermoregulatory zone. And then I know I said that in symptomatic women it's more narrow. I think it stays more narrow. It's just that they respond to the medication.
Okay, that makes sense. We've got another question here about kind of the indications of using elinzanetant or fezolinetant. It's generally just asking, is hormone replacement therapy for people who are eligible still more effective than those treatments?
I think that most clinicians would tell you that hormone therapy remains the primary treatment for menopausal women because it treats the hot flushes, improves the sleep. It does help quality of life, brain fog. Some people are able to better maintain their weight, although it's not a weight loss drug. And then we get the benefit on that acute loss of bone density that happens with menopause, as well as some vaginal improvement. With elinzanetant, we're really going to be treating the hot flushes along with fezolinetant, and then the mood and sleep, we hope we're improving with the elinzanetant, but we're not going to help the vaginal dryness. We're not going to prevent the bone loss. And so in general, hormone therapy remains the primary choice. And for everybody, it's an informed choice because many women will choose not to take it, even if they can. They might be afraid, well, my mother had breast cancer. Well, it turns out if your mother had breast cancer, your biggest risk of having breast cancer is that your mother had breast cancer, and that hormone therapy used at low dose for 3 to 5 years isn't any more of a risk than being sedentary or having more than 2 glasses of wine. So many women who are frightened are actually good candidates, but some women just aren't. If you've had a stroke, if you have had blood clots, if you've got lupus APS syndrome, there are just certain reasons why women can't take hormone therapy. And up until now, all of our non-hormone therapy options just didn't work as well, and they had side effects. So for example, we talked earlier about taking antidepressants low dose. So they do improve the hot flashes, but they also can affect libido, and they don't give you any of the other benefits. So you get side effects from taking it as well as loss of libido, but your hot flushes and maybe your sleep are improved. So I think that up until now, until these new neurokinin receptor antagonists came, we just didn't have good, effective, safe therapy.
That makes sense. Thank you. Just looking at the time, I realized that this is going to be our last question, if that's okay with you. So this question is also very long. It's related to cardiovascular disease, so I'm not sure that you'll be able to address it, but do you have any thoughts going forward about measuring arterial stiffness in women going through these treatments and intervening to improve vascular health, potentially to decrease the vascular symptoms that they might be experiencing?
I'm going to tell you that I think that is a great research project and would be very excited. I think we have to remember that elinzanetant is under FDA review, so it's not even here. Fezolinetant has been on the market since May of 2023, and they've had the liver issue and just, difficulty with cost and getting it out. So, most of the focus is still trying to get this available for the people who have hot flushes. But I know that if the NIH doesn't want to fund some of this, that the companies that sponsor this, and it's Astellas for fezolinetant and Bayer for elinzanetant, will be interested in, investigator-initiated research. And I think that that's going to be very exciting because my bet, I'm hearing Rebecca Thurston in my ear, is I think it's going to work.
Amazing. Love the positivity there. I did want to direct the audience to the handouts tab. I did put Dr. Pinkerton's paper that she provided me with in there, so you can access that handout going forward. And JoAnn, I want to thank you so much for your time, your expertise, and sharing your work with us today. Your patients are really lucky to have you, and we hope that you had fun.
It was a great pleasure. I wish I could answer all the questions, and thank you for having me.
No problem. Okay, and to our live audience, I want to say thank you. We know you have really busy schedules, so we appreciate you being here live and hope that you enjoyed your experience today. Please join us for the next and final event in the series, which is next week on Wednesday, February 26th at 11 a.m. Eastern Time. You will receive a reminder email with the link to log in, so be sure to block it off in your calendar. A quick reminder that a recording of today's webinar will be available soon, so keep an eye out for an email giving you access to that. And additionally, that survey will appear again at the end of this webinar. We do read all of your comments and appreciate your input on your experience today. And you can also let us know what topics you'd like to see in the future. And lastly, if you have questions for JoAnn, you can still continue to submit them in the Q&A tab and also in the additional questions, comments, and feedback section of the survey, and we'll pass them along to JoAnn. In closing, we hope that you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society, and we'll see you next week.